So there's nothing I can press here. Ah, there it is. There's Melanie and her baby. Okay, so as many of you know, urinary tract infections are extremely common, and they're primarily caused by the bacterium uropathogenic E. coli. And as many of you also know, that not only are UTIs extremely common, but the risk of recurrence is extremely high. And as women age, the risk of UTIs increases considerably. And the loss of estrogen that comes with menopause is thought to be one of the risk factors that leads to this increased risk of UTIs. So what we decided, and as many of you who are urogynecologists know, and you prescribe vaginal estrogen, topical vaginal estrogen therapy, which has been shown to decrease the risk of recurrent UTIs. But the mechanism of action in the urinary bladder and the mucosa is not fully understood, and dosing recommendations are not standardized, nor is it evidence-based. So when Dr. Melanie Meister joined my lab about a year ago, she decided to start a prospective cohort study trying to understand mechanisms behind this efficacy of vaginal estrogen and also to look at the risks. And what she did was to design a study where she recruited 3 groups of women, all postmenopausal, with or without a history of urinary tract infections, and who have been or have not been on vaginal estrogen and who was started as part of the study. The study is ongoing, but upon enrollment, we've started many of our patients on vaginal estrogen, and we collect samples, urine and sera, at 3 months and 6 months. And when we had the samples during the research period when Melanie was in the lab, she did comprehensive cytopathologic analysis using both qualitative analyses, such as doing cytopathology, which I'll show you pictures in just a second, for inflammatory influx into the urine, as well as quantitative analysis looking at levels of serum cytokines. So what we found, this is a visual just showing the 3 groups of women. On the left is group 1, where the women don't have a history of recurrent UTIs. And on the right are a group of women that have a history of recurrent UTIs and are currently not on vaginal estrogen. The blue cells that you see are the inflammatory cells that are recruited to the bladder mucosa upon a UTI, and the yellow or the larger cells are the urothelial cells that are shed in the urine. And we can quantify this and give a pretty decent view of what's happening inside the bladder mucosa based on the urinary cells. And this can be quantified to generate an inflammatory score, and you can see highlighted in blue are women that have a history of recurrent UTIs that have been on estrogen, or we have started them on estrogen, and they tend to have a lower inflammatory score than those women who have a history of UTIs but are not currently or have not started on vaginal estrogen. So certainly estrogen therapy appears to reduce this inflammatory influx. Another thing that we've known for a while, and we've done studies in our animal model as well as in our women, is that in general, postmenopausal women, even without a history of UTIs, tend to have higher circulating levels of the cytokine interleukin-6. Now, IL-6 is a cytokine that's activated or directly upon the first infection and is very important for recruiting both neutrophils and macrophages to the site of infection to deal with the infection. And what happens is in postmenopausal women that even at baseline there's a higher circulating levels of cytokine, of IL-6. And one reason for this is possibly that estrogen, the hormone, actually binds to binding sites on the interleukin-6 promoter, and during menopause, when you have lower levels of estrogen, this repressive activity is taken away, and you have higher levels of the circulating cytokine. And you can see in the graph that whether or without a history, there's increased cytokine levels. And this is very preliminary studies showing that if you give vaginal estrogen therapy, you can somewhat decrease this interleukin-6 production in the urine as well as in the serum. So in conclusion, what our study is saying so far is that vaginal estrogen therapy might be working in treating or in preventing or limiting the damage from recurrent UTIs by modulating the inflammatory profile, in part by reducing the excessive levels of IL-6 and therefore reducing the excessive recruitment of immune inflammatory cells to the bladder mucosa. And as Melanie continues her project, we're going to continue increasing our enrollment numbers, as well as conducting further urine and serum analysis to determine the mechanism and ways to intervene. And with that, I want to highlight again Dr. Melanie Meister, who's done the work, and other members of my lab, as well as our funding. And also want to acknowledge Dr. Jerry Lauder, who's the Division Chief of Urogynecology at Washington University, who's here in the audience, and our funding. And thank you very much for your attention.
Well, this paper is open to discussions.
Only one short question.
Hello. Hello.
I don't know where you are. Okay.
Yes,
Hello. Thank you very much. Could you tell us the polymorphonuclear leukocytes? So you just count them per high-powered field?
Correct.
And is that spun urine or unspun urine?
It's spun urine.
Okay.
But it doesn't have to be spun. It depends on if you're getting it fresh or if it's frozen. And we have a series of stains that we can do to be able to be very clear whether these are PMNs that are freshly arrived in the mucosa or have been there for longer.
What stains?
I don't think I had the list on there, but we can do a Pap stain, which gives us a lot of information about the urothelial cells relative to vaginal or urethral cells. And a modified Gimsa stain and a HEMA3 stain, which tells us about neutrophils.
And are you using estriol or estradiol therapy?
It's the vaginal, it's Estrogen, I guess. It's a cream that's prescribed, yes. Thank you very much.
Thank you.
Thank you very much.
Next paper is the association between urinary incontinence and disordered eating, a comparative study between female elite athletes and non-athletes by Alice Carvalho.
Good afternoon. I would like to thank the opportunity to present our work. And I have no affiliations to disclose. So in recent years, studies on urinary incontinence and disorderly eating have shown higher prevalence of both conditions in female athletes compared to controls. However, to date, few studies have addressed the association between both conditions controlled for covariates. So the aim of our study was to assess the prevalence of urinary incontinence and its association with disorderly eating among female elite athletes and non-athletes. So athletes from different sports competing at an international level were compared to non-athletes. The sample comprised young women with no comorbidities. All data were collected by self-report and validated questionnaire were applied. We used the ESIC questionnaire for urinary incontinence and the eating disorder questionnaire, examination questionnaire for the disorderly eating. So, prevalence of UI was higher in athletes, considering here all type of urinary incontinence and stress urinary incontinence. Regarding disorderly eating, no difference were found neither between athletes and non-athletes, nor between athletes from Linus and non-Linus sports, considering the global score. Regarding the association between both conditions, whereas in non-athletes there was no statistically significant difference in prevalence of UI of any type between those with or without disorderly eating. In athletes, prevalence of UI of any type and stress urinary incontinence was higher among those with disorderly eating. So, we estimate the magnitude of the association between disorderly eating and urinary incontinence, and the results show that athletes with disorderly eating were about 3 times more likely to present UI of any type in comparison to those without disorderly eating. Female athletes, in conclusion, with disorderly eating have higher risk of UI than other athletes, suggesting that disordered eating could play a role in urinary incontinence. Both conditions can have a negative impact on the athlete's well-being, quality of life, and sports performance. But there is a need for further studies to elaborate on mechanisms for this association. Thank you.
It's open for discussion.
Thank you for this interesting presentation. Can the mechanism be some maybe atrophy or loss of muscular tissue or some supportive tissue to the urethra in these females who are having eating disorders and can lead to easiness to have incontinence? Is it a reasonable idea?
Perhaps because the athletes, in order to maintain a low body weight, they can engage in altered behaviors. So macronutrients and micronutrients, they can have not macro and micronutrients that they need to build muscle. So maybe this could have an implication on the function of the pelvic floor muscles.
Thank you.
I'm Beatrice Littal from Switzerland. Thank you for the speech. I wanted to ask, I just wonder, how did you get the responses? Was self-administered?
What? Sorry?
Where you get your answers from the people? Was it the questionnaire? Was it self-administered?
Was the questionnaire.
Yeah, for both conditions?
Yes.
Urinary incontinence?
Yes, by questionnaire.
Okay.
Okay, thank you.
Thank you. Thank you.